Initial experience with per-rectal endoscopic myotomy for Hirschsprung's disease. Medium and long-term outcomes of the first case series of a novel third-space endoscopy procedure. Introduction. Hirschsprung's disease, HSCR, is a congenital disorder characterized by absence of intrinsic ganglion cells in submucosal and myenteric plexuses of the hindgut. The aganglionosis leads to loss of propulsive motor activity and tonic contraction of the affected bowel segment due to defective inhibitory innervation and apparently spared excitatory neuronal innervation. Clinically, this results in a distal stenotic colorectal segment with dilation of the proximal colon. Functionally, this is similar to other gastrointestinal neuropathies like achalasia cardia or gastroparesis. HSCR and achalasia cardia share similar hallmark manometric findings in terms of absent sphincter relaxation, lower esophageal sphincter or internal anal sphincter respectively. HSCR is classified by the length of the aganglionic segment, involvement of the sigmoid colon, short segment, SS 53.8%, or rectum, ultra-short segment, USS 25.6%, are the commonest variants. Although the traditional treatment paradigm in HSCR has been resection of the aganglionic segment and reconstruction using pull-through operations with coloanal anastomosis, these operations are invasive and carry high morbidity. An alternative, surgical posterior anorectal myotomy or myectomy, has been described, based on the principle of disruption of the spastic aganglionic segment. This technique was effective in patients with USS HSCR limited to the distal 5 to 8 centimeters. Third space endoscopy permits performance of longer or tailor-made myotomy, as is evident from peroral endoscopic myotomy, POEM, for achalasia cardia and G-POEM for gastroparesis. Based on this philosophy, per-rectal endoscopic myotomy, PREM, was conceptualized, successfully performed, and reported by the authors group in the form of 2 case reports and 1 conference abstract on adults, followed by pediatric and infantile SS-HSCR patients. The current case series reports a single-center experience of PREM for SS-HSCR patients with medium-term to long-term follow-up. Methods. Retrospective study of SS-HSCR patients diagnosed on history, contrast enema, rectal biopsies, and anorectal manometry, and treated by PREM. The aganglionic segment was mapped before PREM was performed using third space endoscopy principles. Stool frequency and laxative usage before and after PREM were compared. Results. 9 patients, age 7.5 plus or minus 5.2 years, 7 male, underwent PREM during a 4-year period. Mean aganglionic segment length was 6.3 centimeters, mean procedure time 96.1 minutes, and mean length of hospital stay 2.5 days. Median follow-up was 17 months, range 9 to 58 months. Stool frequency was 1 every 4.4 days before versus 1 every 1.2 days after PREM. Mean laxative usage was 5.4 units of laxative, UL, before versus 0.4 UL after PREM. No laxatives were used by 6 of 9 patients after PREM. The single adverse effect seen, anal stenosis, was treated with dilatation. Conclusions. PREM is a safe and effective minimally invasive procedure to treat SS-HSCR and results in long-term response.